So this is just an introduction and of what we'll talk about today. I thought I would start with an introduction of the sort of the landscape of cancers. I'm a GYN oncologist, and so my area of expertise is cancers of the female reproductive tract, and that's specifically the uterus, the ovaries, and the cervix. And what I'll do is I'll review sort of the traditional treatment strategies that we have now, and then try to bridge that into why I think that we need to do better. And the newest strategy that we're looking at now is using the body's own immune system as a means of combating cancer. Sort of the newest strategies for immune modulation include something called checkpoint inhibition. And that's a way of, that sort of builds on what we now know about the sort of the machinery and the intricacies of the immune system and how we can pharmacologically manipulate that. And I'll present some of the clinical experience that we have in human cancers in general, and then sort of swing back and circle back to how this relates to the gynecologic malignancies. And throughout this talk, I'll use cervical cancer as our case study. And at the very end of it, I'll circle back. At the very end, I'll conclude with some final remarks and some summary statements as to what is out on the horizon. And so the graph on the left sort of depicts the prevalence of human cancers in women. And as you can see here, the orange arrow points to uterine cancer, which in 2014 and 2013, 2014, affected almost 50,000 women in the United States. And as you can see on the graph on the left, this is an escalating malignancy, and that's largely due to the increasing rates of obesity in the United States and other industrialized nations. In the blue arrow at the bottom, you can also see that ovarian cancer is the number 9 most commonly diagnosed cancer in the United States among women, and yet it accounts for the number 5 cause of cancer-related death among women in the United States. And this sort of speaks to the fact that ovarian cancer is usually detected in advanced stages. You may ask yourself, well, if I'm going to use cervical cancer as a case study, why isn't cervical cancer listed on here? And you can see here that the rates of cervical cancer in the graph on the right, cervical cancer accounts for about 12,000 new cases in the United States annually, and only about a little under 5,000 deaths per year. Then that's within the United States. Well, worldwide, we know that cervical cancer is a tremendous public health problem. Across the entire globe, cervical cancer is diagnosed in over 500,000 women each year. So that's over 500,000, and it accounts for 250,000 deaths among women each year. And you can see here, when we split it up between the developing nations and industrialized nations, cervical cancer is certainly a disease that affects these developing nations. And given that this is the NATMA program, I thought I would sort of present some of the statistics of cervical cancer in Taiwan. And it's interesting. So the report that I found in 2010 divided the prevalence of cervical cancer in the pre-nationalized healthcare system and the post-nationalized healthcare system era. And as you can see here, before the national health care program was implemented, it was actually the most commonly diagnosed cancer. And then afterwards, in 2010, it dropped to number 3. And that's probably in part due to increased screening and also potentially adoption of the HPV vaccine in Taiwan. And so this is sort of the landscape of women's cancers. Well, what are the traditional treatments that are offered for women's cancers? And these treatment strategies actually apply to all human cancers. And so certainly we traditionally think of surgery and cutting out the tumor as a primary treatment option. But we know that that is usually not enough. And that's where adjuvant or follow-up treatments using radiation, chemotherapy, and biological agents become very, very important. We know that people die of cancer not because the cancer sticks to the ovary and doesn't go anywhere. People die of cancer because the cancer breaks off from the ovary, spreads throughout the body, and that's what causes death due to cancer. And that speaks to the importance of finding a kind of therapy that is able to treat the entire patient systemically. And so what progress have we made in terms of developing these systemic treatments? Well, in 1999 was sort of one of the biggest improvements in cancer treatment, and that's when the NCI issued its white paper alert saying and advocating that chemotherapy needs to be combined with radiation in order to successfully treat cervical cancer and provide that woman with her best chance for survival. And that was based on these 5 randomized trials presented in 1999 that led the NCI to issue this white paper alert. So that, keep in mind, was about 1.5 decades ago. And so since then, there really have been very, very few improvements in systemic treatments for cancer. And by systemic treatments, again, we want the treatments that cover the patient's entire body, because we know that what causes cancer-related mortality or cancer-related death is when the cancer spreads outside of that organ. And so in 2006, the FDA issued its first drug approval for cervical cancer. Again, this is 2006, so right now we're in 2014, so 8 years ago. And this is basically when the FDA said approved topotecan as a treatment for advanced and recurrent cervical cancer. And they issued this approval based on a 25% reduction in the risk of cancer-related death. Sounds like a great achievement, right? 25% lower chance of dying. Look at the survival improvement. The people who got this regimen, this newly approved regimen, they lived 3 months longer. So one would argue that while the 25% sounds impressive, the 3 months is a little bit less impressive. Well, what happened this week? Well, this week was actually big news if you follow the GYN cancer literature. I'm not sure how many of you do, but this week the FDA actually issued its first approval since 2006. So this is the approval from Thursday, where the FDA approved Avastin. With the generic name is called bevacizumab, but the common label is called Avastin. So the FDA issued its approval for the use of Avastin or bevacizumab in advanced and recurrent cervical cancer. So this is actually a biological targeted agent against the blood vessels that grow to feed tumors. Again, they made this recommendation for approval based on a 25% reduction in the risk of death in patients who got bevacizumab combined with 2 other chemotherapy agents. And what does this translate into? Well, it translated into a 4-month improvement in overall survival. So it's a little bit better, but it's still there's still a lot of room for improvement. So that 4-month improvement translates into women who got the bevacizumab with the chemotherapy. Their overall survival was on average approximately 17 months, so about 1.5 years. So again, I think that even though these are tremendous studies, very expensive studies, and very well done studies, I think that there's significant room for improvement. And why is that? Because generally, look at these numbers: 17 months, 9.5 months with these newfangled, newly approved FDA drugs. I'm in general a little unimpressed. And so this is why I think that we can and we really should, as physicians and scientists and educators, do better. And this is why I think that immune therapy is a strategy that we should look into. And so, the whole concept of using the immune system to combat cancer is not new. And in fact, as you can see here from this timeline, it dates all the way back to the 1800s, when Coley used a streptococcal inoculum on patients and saw that it made some of the cancers shrink. And that was sort of the first sort of non-IRB approved way of testing whether or not something had any sort of anti-cancer activity. And as you can see here, over the years, there have been a few landmarks, but again, brings us all the way down to here. And I highlight here in the orange one of the seminal findings that has really pushed forward the immune therapy in cancer, and that is the detection of tumor-associated antigens, and also the fact that the immune system can identify these tumor-associated antigens as foreign objects and mount an immune response, and therefore go ahead and elicit tumor cell kill using the body's own immune system. And so what is the relationship? How did all of this come about? Well, there was a lot of epidemiologic data that suggests that there was a relationship between the immune system and cancer. And a lot of this, unfortunately, stemmed from the AIDS epidemic, the HIV/AIDS epidemic back in the 1980s, when there was a whole host of people with HIV and AIDS who were developing a lot of unusual malignancies. And then they also saw that when those patients with HIV and AIDS, when their immune systems were reconstituted and improved, the frequency of those cancers diminished as well. from a laboratory standpoint, there was the detection of when laboratory techniques were refined, they were actually able to take biopsies of tumors, look at it under the microscope, do staining, and determine that there was actually immune cells mixed in with those tumor cells. So when you biopsy a tumor, you're not only getting tumor, you're getting all of the supporting structures around the tumor that are feeding it and supporting it. And some of those structures were immune cells. But what was key is that those immune cells, in patients whose tumors had a lot more of those immune cells, those patients actually did better compared to those patients who, when you biopsied their tumor, it was all tumor and very little immune infiltrate. And so sort of those two lines of evidence taken together really supported the pursuit of the immune therapy for cancer. So let's circle back to the GYN malignancies. And so why do I use cervical cancer as a case study? Well, cervical cancer I chose cervical cancer as a case study for immune modulation because cervical cancer has a very clear immune etiology. We know that almost all cervical cancers are due to infection with HPV, the human papillomavirus. And we also know that the human papillomavirus has very clear foreign antigens. These antigens are the E6 and the E7 antigens. These antigens are detectable by the body and by laboratory tests during the HPV infection, and when there's tumor throughout the entire stage of tumor progression and tumor growth. Because these are detectable and foreign, they also serve as potential targets for cytotoxic or T cell or immune cell mediated cell kill. So I just finished telling you that nearly all cervical cancers are due to HPV infection, right? Well, according to the CDC, the overwhelming majority of adults have been exposed to HPV sometime in their lifetime. So if that's the case, why doesn't everybody get cervical cancer? Well, we know that not everybody gets cervical cancer because most people get exposed. They have a transient, meaning a fleeting infection, but their body's immune system is able to clear it up. Those people, they have these immune parameters that suggest that their immune system is able to respond to the amount of response to the HPV, and then they're also able to elicit some sort of a memory to the HPV. And when you compare that, though, to patients who ultimately go on to develop cervical cancer, you can see that the immune response is almost the diametric opposite. These patients who go on to develop the cancer, their bodies don't necessarily exhibit that same robust immune response to that HPV, and potentially that's the reason why they go on to develop cervical cancer. So before we overly enthusiastically jump on the immune therapy bandwagon for cervical cancer, we need to make sure that we're doing it in a logical manner. And really, why do we really think that cervical cancer is something that we can treat immunologically, or actually kind of more on a broader scale? How do we pick a disease or a condition that is most attractive for immune therapy? Well, since we're asking the patient's own immune system to respond and to kill those infected cells, we need to make sure that the body's immune system is able to detect a difference between that foreign cell, or that infected cell, or that cancer cell, versus a normal cell. And we also need to make sure that there's enough of a dose of that foreignness or that difference that the immune system can detect, can trigger that kind of a response. And then finally, we need to be able to see that the presence of those foreign antigens or those foreign particles elicits enough of a danger cell that it triggers the body's immune cells, such as the dendritic cells and the antigen-presenting cells, to identify it, sequester it, and trigger that immune response. And ideally, we'd like for that immune response to last a long time. That way, when the patient gets exposed to it again, the body is still aware and can continue to clear that foreign material. And so, why do I think that cervical cancer would be a good candidate for immune therapy? Well, if you look at the strategy on how cervical cancer is treated with a combination of chemoradiation. This was that NCI broad statement back in 1999. Which said that chemoradiation will induce the most significant amount of tumor cell kill. We also know that those cervical cancer cells are laden with HPV, the human papillomavirus, and that those viruses have proteins that are foreign and detectable. So when the chemoradiation is applied to the cervical cancer cells, that results in lysis or breaking open of those cervical cancer cells, thereby releasing all of those HPV antigens. that can then be, those antigens can then be taken up by the dendritic cell and presented to your T cells or one of your immune cells. Those T cells require two signals, a signal 1 and a co-stimulation signal. And by the activation of signal 1 and the co-stimulatory signal, that leads to the full expansion of a robust and durable immune response. A robust, meaning a strong enough, and a durable, meaning it lasts a long time, immune response. And because of this hypothesis, this is why we think that immune therapy would be a good modality to pursue for cervical cancer. Again, the viral antigen for cervical cancer is foreign, so it's definitely not self. So it fits a lot of the criteria that I had outlined earlier. And so we know that the immune system requires those two separate signals in order to generate that fully robust and durable immune response. But yet we also know that no immune response and no single physiologic pathway can travel unchecked. There need to be safety mechanisms in order to not let it run rampant. And so what are some of those? And so what are some of those safety mechanisms? Well, those are sort of generally called the checkpoint inhibition or checkpoint inhibitors. And the first one, and this is sort of the hottest topic in oncology today, and it will probably continue to be one of the hottest topics on oncology within my lifetime and probably everybody else's. So the first checkpoint inhibition is called CTLA-4, which stands for cytotoxic T lymphocyte antigen 4. And so what CTLA-4 does is it serves as a primary checkpoint of the immune system. So as I said earlier, the antigen-presenting cell requires the T cell gets activated when both signal 1 and the co-stimulatory signal are activated upon presentation of the antigen by the antigen-presenting cell. And this activation of both the signal 1 and the co-stimulation leads to the expansion of the immune response. Well, when the immune response is no longer needed, then then CTLA-4, which is depicted here as these little yellow pegs, blocks the co-stimulatory signal. Without that co-stimulatory signal, the immune response does not have enough momentum to go forward, and therefore the immune response turns off. This is your body's way of preventing you from developing autoimmune disorders. And so why do you need that? Again, this is a safety. This is your sort of your body's own physiologic safety mechanism to prevent untoward damage to normal tissues. And so, is this something that we can pharmacologically target? The answer to that is yes. And so the pharmacologic agent is called ipilimumab. This is a monoclonal antibody against CTLA-4. And so this is the original diagram that I showed you, where the yellow peg turns off the co-stimulation and the immune system turns off. Well, in the setting of cancer, you don't necessarily want the immune system turned off. You want that immune system going and revving and continuing its tumor cell kill. And therefore, what the ipilimumab does is, it's depicted here by this yellow Y. What the ipilimumab does is it basically blocks all of the yellow pegs or all of the CTLA-4, thereby making it unable to stop that co-stimulation from happening. With the signal 1 and the co-stimulation in action, the immune response stays on, and ideally you get continued cell kill. Well, is there any clinical data to support this? I'm showing you a lot of mechanism and theory, right? So is there any data in patients to support that this might work? And the answer to that is yes. And most of it is in the melanoma literature. And the reason why most of it is in melanoma literature is because melanoma actually is a very highly antigenic cancer. There are a number of when you do a biopsy of a melanonic lesion, there's a significant amount of T cells and within the melanoma lesion, and therefore, a lot of the immune studies have been based on the melanoma population. In addition, melanoma affects over 70,000 people newly diagnosed in 70,000 people in the United States each year, and out of those, 10,000 die due to melanoma. So it has a high mortality. And so what is the clinical basis to suggest that blocking CTLA-4 would work for melanoma? Well, this is actually one of the phase 3 clinical trials that led to the FDA approving ipilimumab for melanoma. So these patients who all got these treatments A group of them got ipilimumab, that anti-CTLA-4 drug. A group of them got this GP100, which is basically like a vaccine against one of the melanoma antigens. And then a third group got the combination of both of them. And what you see here is the survival. You can see here that at the 50%, the median overall survival for these patients was still quite low. But the important thing you want to know here, and the important thing to recognize here, is not just that the absolute number of people who responded to the anti-CTLA-4 blockade, but rather it's that the x-axis here is years. You have a group of patients all the way out here at 4 years out who are actually still alive. 25% of the people who had gotten the ipilimumab alone are still alive at 4 years. These are patients who actually had a death sentence, and yet they're still alive 4 years out. In the world of oncology, being alive at 4 to 5 years is considered a cure. And so this was sort of revolutionary in its time, and this was published in 2010. Well, what about if some people would argue like that this is just because those patients didn't actually get chemotherapy and they were just getting this vaccine against melanoma, this GP100, and maybe if we gave them chemotherapy, they would have done better. So of course they tested that, and of course the same relationship held true that if the patients got the ipilimumab or the anti-CTLA-4 blockade, again, those are the patients who actually, over 25% of them, were still alive 4 years out. Certainly you can argue that there's a group of people out here who got the chemotherapy who are still alive, about 10 to 15%. But essentially, the administration of the CTLA-4 blockade resulted in a 30% reduction in the risk of death compared to chemotherapy alone. And again, the absolute difference in terms of the absolute number of months is, again, very, very, very modest, 2 months. But again, this is a disease where the patients have a very, very, very poor survival. And so certainly CTLA-4 was sort of the first of its kind in terms of immune checkpoint inhibition. And I think the newest sort of target that we're looking at now is called PD-1, or programmed cell death protein 1. And there's been a tremendous amount of news about this, and I think that this is the new darling of the cancer world. And so what is PD-1, or what is programmed cell death protein 1? So PD-1, again, is another checkpoint, is another immune checkpoint. And again, remember that the purpose of these immune checkpoints is so that your own body's immune system doesn't run away like a runaway train. It needs a safety checkpoint. And so so PD-1 is actually is a normal physiologic function to prevent a hyperactive immune system. When the T cell gets activated during times of infection or cancer, and we'll just use infection for the time being, when the T cell is activated, it produces activated T cells will have PD-1 on their cell membrane. Normal cells will over time express PD-L1, which is depicted here in this little purple peg. When PD-1 and PD-L1 bind together, this binding together will go on to silence or to deactivate the immune system. This is a normal cell. Why does a normal cell want to deactivate the immune system? It wants to deactivate the immune system so that the immune system doesn't accidentally hurt it. And so this is actually occurs in the effector, or in the tissue part of the immune response. And this deactivation of the T cells is really your body's own way to protect these activated T cells from eating itself or from damaging itself due to unchecked activation. Well, how is this related to cancer? Well, cancer is very clever, as we all know. And so cancer and cancer cells have found a way to exploit this PD-1 checkpoint. So tumor cells now know that, since normal cells can protect themselves from activated T cell killing by expressing PD-L1, these purple pegs, the tumor cells will over time also express PD-L1, that same purple peg, in order to turn off the body's immune response and therefore deactivate the T cells and thereby evade the immune system. And so this is a very clever strategy that tumor cells have adopted as a means of self-preservation. Well, just as clever as tumor cells are, I like to think that humans are just as smart. But so we as humans, we've come across a way to pharmacologically interrupt that sort of immune preservation. And there's two strategies that have evolved. One is blocking PD-1, which is the black fork on the T cells. And then the second strategy is blocking PD-L1, which is the purple peg on the tumor cells. And so it doesn't really, I think fundamentally it doesn't really matter. There are several nuances as to which strategy is better, blocking PD-1 or PD-L1, and that's really beyond the scope of this particular talk. But suffice to say, I think the fundamental theme is that you want disruption of the relationship between PD-L1 and PD-1. Once this association is broken apart, be it by this green square or this green arrow, the end result is the same. Your T cells stay activated, and you get continued cell kill. And that's what you want in the setting of cancer. And so again, what is our clinical experience with what is our clinical experience with this? Well, again, it's with the same melanoma cancer. But in addition, there are a number of other cancers that have really surfaced. And this is largely because we know that the relationship between PD-1 and PD-L1 is not so much due to having an antigen stimulate trigger the immune response. Rather, it's sort of what is going on in the tissues that the immune system is responding to. And I think that's why the lung and the bladder cancers have suddenly come into play. And as you can see here, this is one of the clinical trials using this PD-1 treatment. This one is called nivolumab. But basically what I show here is that with this anti-PD-1 treatment, it actually produces a durable response or durable remission in patients with advanced, non-resectable, pre-treated melanoma. You see here that the survival rate, these are the times of months. So again, these are patients who have a terrible prognosis, but you're getting out to 48 months, so 4 years, you still have 30% of people still alive. This is unheard of in the melanoma literature. Again, and then this is the tumor-free survival period. But I think what you look here with these individual plots is that each line represents one particular patient. And you can see the time since the patient starts treatment, you can see the tumor shrinking, and it's still staying down. 100% change in the size of the lesion, size of the tumor on the CAT scan since they started treatment. This is 100 weeks out from starting the treatment. And then again, this is the same concept. These are just different doses. And so, I mentioned that the CTLA-4 affects the immune system at the trigger point. It triggers the immune system and keeps the immune system going. And then PD-1 is at the tissue level, sort of at the effector stage. Well, they seem to act at two very distinct areas of the immune response. So the idea, or the question that comes up is, can you do better if you combine the two? So what if you block this initial priming phase of the immune response when it's just when it's producing its activated, robust response? What if you block the brakes and allow that to keep going? And then what if you prevent the tumor from masking itself from that response? Then can you improve your outcomes? And the answer to that is probably yes. And so Jed Walchuk, he's from Memorial Sloan Kettering, so he actually published this last year where he did just that. He combined the anti-CTLA-4 treatment and also the PD-1 blockade. And what he found was basically a very deep 100% reduction in tumor size, 100% reduction in tumor size in patients with advanced unresectable melanoma. Again, patients who have a terrible prognosis. And not only did he have a really deep response, this response lasted a long time. And again, this is something that the key with immune therapy is not so much how many people are going to respond. It's that the people who do respond, boy, do they respond for a long time. You've actually given them some degree of hope that they may be cured from their disease. And so I'm just going to wrap up here with sort of some summary statements. And so as I said earlier, I'm a GYN oncologist, so women's cancers. I don't treat melanoma. But I think that a lot of the principles that we've learned here with immune therapy can be translated to the GYN cancers. And I cited cervical cancer as a case study for this. And sort of with that in mind, I started this clinical trial that was sponsored by the NCI back in 2012. And this is a phase 1 study studying anti-CTLA-4 treatment for newly diagnosed patients with high-risk cervical cancer. So cervical cancer, newly diagnosed, but they have a high likelihood of not achieving 100% cure by standard chemotherapy, chemoradiation alone. And so again, these are the high-risk patients, and this is a clinical trial that's currently in progress. These are some of the details about the clinical trial. So, I mentioned earlier that, that these immune therapies, the key with immune therapies is it's not so much how many people respond, it's that the people who do respond, boy, they respond a long time. So wouldn't it be great if we could just figure out who those people are who are going to respond for a long time and then just treat them with this immune therapy instead of subjecting everybody to this immune therapy when not all of them are going to respond, because certainly there are side effects. And so that's actually the purpose of a lot of these what we call translational endpoints, where we're basically trying to paint the landscape of the immune system over the course of being newly diagnosed with cervical cancer, getting chemoradiation, and then getting these immune modulating drugs. And the goal with this is that hopefully we'll be able to paint a picture of somebody who's going to have maybe an immune profile who would be more likely to benefit from this type of treatment strategy. Well, my clinical trial is in patients with newly diagnosed cervical cancer, and there's actually we have a partners trial that's ongoing right now for patients who have metastatic and recurrent cervical cancer. And this is actually run through the Princess Margaret in Toronto, the Princess Margaret Cancer Consortium, in conjunction with the California Cancer Consortium, of which we're a member. And it's studying basically a very similar thing, but in the recurrent population. I think things that are on the horizon that are important to keep your eyes out for, as I mentioned earlier, PD-1 is sort of the darling of the immune oncology field right now. And so certainly there are a number of anti-PD-1 trials that are currently in development, and they will be active probably within sometime in 2015. These trials are in cervical cancer and also ovarian cancer. Why ovarian cancer? So ovarian cancer apparently there are a number of very specific tumor-associated antigens that are detectable on the surface of ovarian cancer cells. And again, that fits the criteria of of the cancer cell having some sort of a different profile or different appearance that can generate that immune response. In addition to CTLA-4 and anti-PD-1 therapies, there are also other immune super strategies. There's a certain bioattenuated Listeria platform that conjugates Listeria to a super toxin and delivers its toxic payload to the cervical cancer cells. And I think I would encourage anybody who's interested in this to look at clinicaltrials.gov. This is an NCI-sponsored government-sponsored website that basically lists every single clinical trial that is registered in the United States and abroad, so internationally as well. And I think that these are not just cancer-related clinical trials, importantly. These are also prevention, cardiovascular, diabetic, and also registry-type trials. And this is sort of the face page of clinicaltrials.gov. Basically, you would just type here, cervical cancer, and then CTLA-4, for example, and then hit search, and it would produce all of the trials that are active, the ones that are pending, ones that have unknown status. And I highly encourage people to do this. You can see here that there's a huge number of clinical trials studying these immune modulators, 49 active studies in CTLA-4 in cancer, 32 in PD-1, 31 in PD-L1. And so I think that this is certainly a very hot area. And so I think, in conclusion, obviously I think the immune system has a very clear role in cancer, both cancer progression and also cancer progression, recurrence, and also over the course of treatment. And I think that this is something that we're still learning a lot about as time goes on. We know that the immune system has a series of checks and balances in order to prevent our own immune system from accidentally injuring ourselves during its course of action. But we also know that these checkpoints or these sort of safety nets can be sort of manipulated so that we can maximize the ability to kill cancer cells. I think sort of looking in the future, there are a number of unanswered questions, and I think one of them is one of the big ones that are the ones that we're trying to answer with our study is which patients can we give these immune therapies to, and is there a way to predict which patients would benefit the most from them? These immune therapies, I didn't go into it during this talk, but these immune therapies, of course, have a whole slew of side effects, which is why they have very strict entry and exclusion criteria for going on study. And so it would be nice to be able to pick a priori which patients would benefit as opposed to just absorb the risk of these studies. And then in addition, I present sort of the checkpoints or the various immune checkpoints, but the immune system is highly, highly complicated. And we know that the cancer cells are highly clever in escaping the mechanisms that we've identified. And anyway, this is a matter of time before I think we're able to sort of corner it into corner it at least in the realm of how our immune system can fight it. So I think at this point, if I'm open to any questions if anyone has any. I think I stayed within my 30 minutes allotment. Pretty good.
Thank you very much.